Good morning, everyone. It's Jean Marie. I'm going to talk to you now about chapter 42, which is care of male patients with prostate problems and the male reproductive problems. Today's objectives are to identify the assessment findings of benign prostatic hyperplasia. We're going to talk about nursing implications and pharmacological management of BPH. We're going to define evidence-based post-operative plan of care for these patients. We're going to develop a teaching plan for men to prevent and detect prostate cancer. And we're going to discuss treatment for the care of patients with prostate cancer. Benign prostatic hypertrophy is, and that it's BPH, and that's what I'll probably end up calling it for the majority of this lecture. That's BPH. It's benign prostatic hypertrophy. Um, it's very common in about 80% of all men over the age of 80. With aging, the hyperplasia of the prostate gland and the inflammation and enlargement of it. We have it extends upward towards the bladder and inward, causing bladder outlet obstructions. They can have urinary elimination problems, lower urinary tract. You have increased residual urine and chronic urine retention. They may have overflow incontinence or urine that leaks or dribbles. The prostate can become large, and the person is unable to void. Before we move on into assessment, I do want to talk about some of the risk factors for having BPH. Again, it's over the age of 80, obesity, diabetes, testosterone, or other supplements, and decreased physical activity can all be risk factors that can lead to BPH in your male patient. Benign prostatic hypertrophy affects about 8% of men under the age of 40, 50% under 60, but again, remember it's 80% over the age of 80. So there are some modifiable risk factors, but there are some that are not as modifiable. A lot of times, men do not like to discuss reproductive issues or problems with their prostate or other reproductive issues with healthcare providers, whether they're male or female. They just don't like to talk about it, but they are more open usually with a male provider. But a lot of times, these patients will prefer. They don't like to talk about it. So one way that has become available to us to help to assess these patients is the International Prostate Score. And this is a self-assessment score that the patients are able to fill out on their own. And it kind of allows them to start the conversation without having to speak. And I think this is very helpful, especially in primary care and in family practices, of course, in urology offices as well, because it gives the gentleman a chance to talk about problems without having to bring up the subject by just filling out this simple questionnaire. And if you look at the International Prostate Score on page 1475 in the written text, it is figure 72-2 for those of you who have the electronic version of the book. It looks at different, it's a self-assessment scale that the patients are able to complete on their own. And what they can do is it talks about whether or not they have incomplete emptying, whether or not they have frequency issues, intimacy issues, urgency. And so it goes through all of these questions, and then it gives the gentleman a score. And so it gives the primary care provider the ability to talk about these score results at the beginning of the physical exam. Along with the International Prostate Score, you also want to ask the patient if they have issues with hematuria, which is blood in the urine, when starting their urine stream. At the end, it can be either at the beginning or at the end of voiding. Because with BPH, especially in elderly gentlemen, hematuria can be a sign of infection from urine flow being restricted and having urinary retention. The prostate exam is performed by a healthcare provider. It is a is called the digital rectal examination, or DRE. Um, it is performed usually while the patient leans over an examination table. If the patient's unsteady or unable to do so, they are placed in the fetal position. The role of the nurse in this may be to assist with holding the patient if he is elderly and unable to hold his weight, or maintain the fetal position without someone to be able to support the patient. If a patient asks you, so what exactly is the doctor looking for when he's performing or she is performing the digital rectal examination, you want to tell them that he or she is looking for enlargement of the prostate. If the prostate is stony hard, it can be a sign of cancer. It'll have like stone-like nodules. If it is hypertrophy, it'll be more elastic feeling and more firm, but not necessarily stony in feeling. So that's what you can tell the patient that the provider is looking for when performing the digital rectal examination, that they are looking for prostate problems, whether it be BPH or prostate cancer. Moving on into looking at lab diagnostics. A lot of times, if these patients are having difficulty with their prostate, the physician will order both a urinalysis and a urine culture, as well as a CBC and kidney function tests. He will also order a PSA, and a PSA is the prostatic specific antigen and a serum acid phosphate level, because if prostate cancer is present, you will see an elevation in both of these with you'll see an elevated PSA in patients who have prostate cancer, and it can be just elevated just slightly with prostate cancer. They also, if there is prostatitis, they may also do a CNS of the prostate fluid. Other diagnostic tests that the provider may have performed is a transrectal ultrasound or an MRI, and what this can look for is being able to view the prostate tissue and surrounding structures. A tissue biopsy may be done by a primary healthcare provider if uncertain on whether or not the prostatic problems are benign or malignant. And even though in the book it says a primary healthcare provider, generally what I've seen with these is a urologist performs that procedure, or an interventional radiologist, more than a primary healthcare provider. A lot of times they will send them for interventional radiology. Okay. Another point that we as nurses need to keep in mind is the psychosocial assessment of these gentlemen. A lot of times they'll have nocturia, so they're irritable because they're not sleeping well, or they're embarrassed because of post-void dribbling or overflow incontinence. So it can cause them to avoid leaving home, or for social isolation. They also may have some of their symptoms may be impacting their sexuality or their libido. So these are things that we need to make sure that the patient has the ability to talk to, whether it's with us, a counselor, or their physician. So a lot of times as a female nurse, if I'm working in that environment, what I would do is kind of like bring up that some gentlemen have this issue, and let us know if you want us to try to get someone for you to talk to about these issues, something to that nature. A lot of times this is also something that is listed on a enrollment sheet, or in when they're coming into the office at a urology office, so that then they can align them with the correct counselors to discuss their issues. When looking at outcomes and interventions when discussing BPH with a patient, so this is after they've completed the assessment findings, they found out it's not prostate cancer, it is benign prostate hypertrophy. How are they going to treat it? Drug therapy is the first line of treatment for these gentlemen. They are usually treated with a 5-ARI medication as the first line of drug therapy. A common 5-ARI is the finasteride, which is used most of the time as the first line of therapy for patients with BPH. A second line of drug therapy that is also used a lot of times in combination with the Poscar, you will see an alpha-1 selective blocking agent such as Tramflo or Flomax. And what it does is it works with the alpha adrenergic receptors in the prostate, which is where the smooth muscles are enabled the prostate gland to respond to it. So again, a lot of times these medications are used in combination, and that would be the 5-ARIs or the finasteride. The second line of therapy is also a lot of times an alpha-1 selective blocking agent. Again, a lot of these times these are used in combination, and that's the Tramsolide. Most of the time, these patients are treated with a combination of medication therapies. Other things that can help and other interventions that are useful for these patients is to avoid large amounts of fluids in a short period of time, like guzzling down a bottle of water, avoiding alcohol and caffeine because both can work as diuretics. Also, voiding as soon as they feel the urge, and to not go too long without voiding. Also, to avoid drugs that can cause urinary retention. Now, keep in mind that combination drug therapy seems to be the best option for these patients, and non-surgical management is always the first line of therapy. But some of these patients do not respond to drug therapy alone and require surgical management. The person who is for surgical management are patients who are not candidates for non-surgical management or who don't want to take medications for the rest of their lives, or other treatment options have been extinguished and are not being affected. The gold standard for care of the benign prostatic hypertrophy is the transurethral resection of the prostate, or the TURP. And we will discuss that in the next presentation.